to hear about how these roles can be used in practice to address health inequalities, I'm really delighted to welcome Dan Hopewell as our first speaker. So Dan is the Director of Innovation at Bromley by Bow Centre, a pioneering health community which uses place-based approaches to work with those at the sharpest end of health inequalities. He's been at the centre for 20 years and has also worked as a regional learning facilitator for social prescribing in London. Dan has been at the forefront of innovation and rethinking how we approach health and health inequalities. Dan, over to you.
Thank you very much, Nina. Sorry, I was just unmuting myself. So I thought I'd just sort of start off this talk with just understanding what we mean by health inequalities and just grounding ourselves in that and taking a bit of a picture, looking at what that looks like across London. And I think we often feel that health inequalities are an inevitability, but of course, if one looks at different societies, different countries across, say, Western Europe, the levels of health inequality are very, very different from one country to another. And indeed, in the UK, unfortunately, health inequalities have been growing considerably over the last couple of decades. And it's by no means an inevitability. So we need to really think about that. But what are health inequalities? Well, as what I've just said might suggest, they are avoidable, they're unfair, and they're caused by the systematic differences within society that then leads to these systematic differences in the health of different groups within society. And those inequalities can play out in a number of different ways, and it's probably just helpful to think about that as we start today's session, really. So what are the inequalities that we're talking about here? Primarily around the health status, of course, the status of the health of different groups of people. And that often then leads to things like differences in life expectancies, for example, or the prevalence of health conditions, or the stage in life at which those health conditions develop. But it also is around inequalities, or is often thought about as around inequalities of access to health, and the availability of treatments. And we know about the inverse care law, actually, that the more deprived communities have less health facilities, even though their need is greater, and the more affluent communities have far better health facilities and a better ratio of GPs, even though their health needs are arguably less, for example. And there are also differences in levels of patient satisfaction, often between different communities or segments of communities as well. And of course, the differences in the wider determinants of health, the causal factors behind the highest percentage of health outcomes, really. And so those are some of the inequalities. And how do they affect different people? Well, they affect different socioeconomic groups very, very differently indeed. So from the most affluent to the most deprived, for example, huge differences, which we'll look at in a second. Geography can play a part in this. Often contrast between urban health and rural health. Surprisingly, not always as you would think they would be between those two, for example. And then specific groups. So you can look at gender, you can look at ethnicity, you can look at age, and think about what the inequalities are within those groups or between those groups. And also people who may face particular issues, such as those who are facing homelessness. So these are some of the issues that we're trying to grapple with when we think about health inequalities, and we think about moving towards a population health approach. If we could have the next slide, please. And the next slide is a little bit of somebody poking a little bit of fun, really, at Cancer Research UK. And so we need to sort of think beyond the obvious in when we're thinking about this. It's very easy to associate cancer with obesity, but perhaps a more profound question might be, what causes obesity? And some graffiti wit has painted up there, poverty, inequality, and austerity. So it's definitely a question of looking beyond the kind of individual health behavioral issues and those sorts of things into what are the causal factors, if we really want to tackle fundamentally the drivers of health inequalities. But that's not to say that we shouldn't also exercise ourselves around where we can exert influence with individuals as well. If we look at the next slide, we'll see the distribution of deprivation across London on the left there, and those are the darker shaded areas, and you can see they are absolutely mirrored by the lighter shaded areas on the map of London on the right, which is the life expectancy level. So the higher the level of poverty and deprivation on the map of the left, the lower the life expectancy in exactly the same areas, absolutely one-for-one mirror on the right-hand map. So deprivation is a major determinant of health and of life expectancy levels. And if we look at we're going to zoom into Tower Hamlets, the borough that I work in the next slide, and we'll see exactly how that plays out in micro. Within a few hundred yards, you have essentially the Limehouse Basin, where the yachting marina is, and the penthouse suites along the River Thames. You have a 20-year healthy life expectancy increase there compared to the deprived housing estates around Mile End. Interest and the 10-year absolute life expectancy difference there. So essentially, poor people getting very, very significantly ill in their 30s and 40s and 50s, wealthy people getting significantly ill in their 60s, 70s and 80s, and then a 10-year life expectancy gap as well. Effectively, poor people living for about a third of their life with one or more, and quite often 2 or 3 long-term health conditions. But ironically or not, accessing the same GPs, of course, and if they get substantially ill, they'll all be down at the Royal London Hospital. So it's not to do with the healthcare that is causing these differences. It's to do with the socioeconomics, and that map again is a map of the indices of multiple deprivation. So you can absolutely see the correlation between deprivation and healthy life expectancy and life expectancy in micro. And of course, we have such great data in the UK that you can practically plot this out, on a lower super output area, which is a population of a few thousand people. If we move on to the next slide, please. One of the challenges for much of London is the level of deprivation in London. It's ironic, isn't it? London's such a wealthy city. Tower Hamlets, 70% of our population are in that shaded area. So that on average, you would expect people to be equally distributed across that graph there of healthy life expectancy along the bottom and life expectancy along the top. In our case, in Tower Hamlets, what we're grappling with is that 70% of our population are clustered in the most deprived 20%, leading to, if we look at the next slide, a considerable difference in consultation rates. And this is where, of course, it gets very interesting for the NHS. If we look at that neon green line, those are the most deprived. And as you can see, the consultation rates in general practice, these are real statistics from Tower Hamlets, shoot up from about the age of 20 in a very, very steep curve upwards. By the time somebody in the most deprived 20% is about 60 years old, they're going to the doctors 8 times a year. But if you look at the blue line along the bottom, those are the most affluent 20%. They start to shoot up actually at about the same age, at about 60 years old. So at the rate at 60 years old, the most deprived are going to the doctors on average 8 times a year. And that's because long-term health conditions have kicked in well before that in their lives. Whereas the wealthy, their long-term health conditions are kicking in maybe when they're about 60 years old. And they're only going to the doctors at that point 4 times a year. So effectively, there's a doubling of consultation rates against deprivation. And this is where social prescribing comes in, of course. So if we look at the next slide, please, we will see, so if we understand what drives ill health, then we also need to think about the flip side of that, which is what drives health, what creates health within our communities. Of course, on the left, we have the seminal work of Michael Marmot, Fair Society, Healthy Lives. And there we have an infographic from the Health Foundation, which essentially is an infographic of that study, which, as we all now know, probably 10% of health outcomes are created, and thanks to the good work of doctors and nurses and healthcare assistants and general practice and hospitals and the NHS, that's probably driving about 10% of the population's health outcomes. And probably somewhere in the region of 70% of health outcomes are to do with those images that are there on that infographic about good work, good neighbourhoods, access to money and resources, decent housing, education, skills, qualifications, good food and a culture of good food in your neighborhood, good transport, family and friends, social networks. A couple that are missed out from the infographic that are in Michael Marmot's study. One is around the life course. And I think when we start to think about population health, in Tower Hamlets, 30% of our 10-year-olds are now clinically obese. Now, a child who is clinically obese is 5 times more likely to be obese as an adult than somebody who wasn't obese as a child. So there's a strong correlation there between childhood obesity and diabetes and heart disease and hypertension and cancers. So if we want to really think about, of course, GPs will say, but hang on a second, 10-year-olds don't come into the doctors. And that's really where we have to start to think creatively about population health. If we're going to think about population health management, it definitely means working with children's centres, primary schools, secondary schools. If we really want to steer the health of the future generations, we don't need to only be working in general practice. We need to be working across our communities. Michael Marmot talks a lot about the life course. The other thing Michael Marmot talks about, and we're going to hear a lot about this from our colleagues in Lewisham, I know, is about community agency, about communities creating their own health and well-being for themselves. If you look at a wonderful infographic, which I've seen of, somebody's got a chronic health condition, how long do they spend in a doctor's surgery? Is an infinitesimally small number of hours in the year that they actually spend in a GP practice. Most of their time, of course, they spend at home, they spend at work, they spend in their neighborhoods. And of course, that's really where we need to affect the change if we are to really start to tackle health inequalities. If we move on to the next slide, please. So this is a rethink of, we're all familiar with these terms, primary, secondary, and tertiary care. At Bromley by Bow, we've rethought these things. Currently, I think it is said that of the £135 billion of NHS budget, 5% is spent on prevention and 95% of it is spent on treating people who are already ill. If we really believe in prevention and early intervention, we've got to move that spending pattern, and we've got to start to invest in what we would consider here primary care as being yourself, your own choices, secondary care, yourself, your own choices, plus family and friends and your close normative behavioral influences, if you like. Tertiary care, the below, plus what you access in communities. And of course, that's exactly where social prescribing is coming in, all the support that people can get in their neighborhood. And lastly, of course, if all else fails, we have the insurance policy, which is exactly what it is actually. It's a health insurance policy. It's the National Health Service that should be there, of course, for everybody who need it, but it should be seen as the place you go to when other things have gone wrong. Where we need to get them right is within our communities. And that's what population health management has to really be about, stepping outside of the confines of clinical buildings and out and into the community. Thank you.
Thanks so much, Dan, for that really inspiring presentation and reminders of some really important concepts, around thinking about those fundamental causes of poor health and how population health fits into that. The concept of health creation and community agency, which we'll hear more about, and the pyramid of rethinking care as well, really centering people and their communities. Some of the questions, so a question that I've got, and also if anybody would like to ask any questions, please do write them in Slido, is how can we effectively use some of our personalised care roles in these population health management initiatives that you've mentioned, such as health creation or creating community agency?
I think one thought is, how do we build local partnerships? The primary care network is a wonderful unit of geography, particularly in London. Primary care networks in London are just about 1 square mile. How do we build the relationships between clinical teams and housing association teams, community centre teams, faith organisations? How do we build those relationships on the ground? And how do we get some of the R's roles out of the clinical settings and working in community centres? Absolutely no reason why health and wellbeing coaches and care coordinators and social prescribing link workers can't work in community settings, in libraries. Some of them do already, but we could do an awful lot more of that sort of thing. But also how we help those community organisations to understand their health promoting role too. How do we maximise the health benefit and the health achievement of children's centres, for example, working with parents around healthy eating and physical activity with their children, for example, or primary schools, for example? How do we create the relationships between the healthcare professionals, who after all have an awful lot of knowledge and understanding around what drives health, and how can they become key supporters and key advocates for other community organisations to maximise the health benefit and gain that they can achieve? How can you work with housing associations to set up walking groups? How do you set up, for example, those walking buses from the local housing estate to the primary school, so that you move from parents driving their children to primary school to children walking with a housing association supporting that initiative? You know, a piece of joined up working, for instance, between the housing association and the primary schools in its area, for example, around walking buses. You know, I think if we start to have those conversations, we will find a myriad of opportunities to work together.
Thank you. Lots of food for thought there, and lots of practical ideas and tips as well for people to think about. Thank you so much for that.